Hello and welcome. Christine Sutherland here, and whether you've connected with me through LinkedIn or you found your way here through some other means, welcome. I'm glad you made it, and I hope you find the material here as utterly incredible and fascinating as I still do, even after all these years. I've been working on this concept for nearly 40 years, but it's really only in the last 20 years, with the benefit of advances in technology and research, that I've been able to crystallise and refine my thinking to develop this very soundly evidence-based theory and practice of multisensory disruption of reconsolidation of conditioned responses as a relatively easy, fast and permanent therapeutic strategy. Thank heavens it's easier to apply than the lingo might suggest it is to understand. I should explain that I didn't want to make this into a schedule-only webinar that you could only watch at a certain time, because I think that's unfair to people who have other commitments or who are challenged by being in different time zones. So I've made it into a view anytime webinar with an option to make comments or ask questions on the same page, because it's really important to me that you get every bit of value that's possible out of this. I hope that works for you, and I promise I'll respond as quickly as possible. Now, I don't want to take up too much space talking about myself, and my bio is on LinkedIn in any case, so I'll just introduce myself as the CEO of the LifeWorks Group, which I founded in 1999 as a research and training organisation, and a peer-reviewed and published researcher who's been practising since 1994 on a mission to share some pretty cool stuff which we've been using and testing for many years. My textbooks have been published by McGraw-Hill throughout Australia, New Zealand and Europe, and also by Jaria through the Arab-speaking world. Today's webinar is specifically about a better psychological approach to treating non-malignant chronic pain, which is not so much about managing the pain or helping the person to live with the pain or to develop a better attitude to the pain, as it is about switching the darn pain off altogether. Because now, with an updated understanding of the real nature of chronic pain, we can indeed switch off chronic pain signalling. So let's cut to the chase and look at why we need such a different approach, completely different to CBT and mindfulness, for example, and also different to strategies like EMDR or EFT. An important meta-analysis published in the journal Pain concluded that there was no treatment that helped the majority of chronic pain patients, and that included pharmaceuticals of all kinds, physical therapy and CBT and other psychological strategies. I assure you this conclusion is shared by a great number of people working in the field of chronic pain. It is entirely uncontroversial. Unfortunately, this represents a truly awful 3 million Australians, many more worldwide, who aren't getting relief and who are suffering badly on a daily basis. The human cost is the worst, of course, but the financial cost to the health system and the community is in the hundreds of billions annually. Now, I'm going to sprinkle some clinical evidence throughout this session today, and the first is our own pilot study from 2001. We've been enjoying what we thought were pretty remarkable results with chronic pain, and we thought it'd be a good idea to put that to the test with a small group treatment project over just 2 days with a 2-year follow-up. In fact, we ended up running 2 of these, but the second had a 100% efficacy rate. So I just put that one aside because, well, 100% just doesn't happen, does it? I didn't think it'd help our credibility to run with that one. So I just wrote up the lesser of the 2, and as you can see, it had an efficacy rate of plus 85% with a p-measure of less than 0.01. Over 60% of the group had complete remission of pain in 2 days. Another 25% of the group had more than 50% decrease in pain, and the remainder had less than 50% decrease. The latter weren't counted in the efficacy rate. But that's just our little study. Other researchers are doing even more exciting stuff, as you'll shortly see. And we do have other papers on our website regarding other issues. One was moderate to severe depression, and the other one was behavioural and academic measures in at-risk children with similarly large results. So how do chronic pain patients show up in our practices? For a start, they might not come along because of pain. It's more likely they've come for some other reason altogether, one of the comorbidities associated with pain or something altogether unrelated. When you consider that 1 in 5 people suffer from chronic pain, the prevalence in our practices is probably through the roof. The person may or may not appear to be distressed, might or might not have trauma, might have difficulty verbalising what's wrong. It might not be at all obvious that they're in great physical discomfort. However, when they're specifically asked for somatic sensations, they often report quite strong ones. You might even be well aware yourself that when people are experiencing a strong emotional reaction, it can include strong physical sensations as well, even very painful ones. So how do these strong physical responses arise? Most people would have no problem describing them as conditioned responses, and in fact that's exactly what they are. What we as a scientific community have been slow to realise is that this is also the mechanism which produces most, not all, non-malignant chronic pain, which I'll demonstrate shortly. Pavlov showed us over 100 years ago that pretty much any stimulus can become a conditioned stimulus, producing almost any response. If we want to take a look at how crazy or weird this can get, consider the case of a smoker. Most of us are well aware that someone can be triggered into a desire to smoke by smelling cigarette smoke, or by having a beer or a coffee, or feeling stressed. But it's also quite common to suddenly get a desire to smoke when opening a newspaper but not a book, when sitting in one particular chair but not another, when walking through one door but not another. Basically anything that happens repetitively with anything else, or that happens with enough impact in the case of a one-off trauma, can become a conditioned stimulus. To extrapolate this to chronic pain, literally anything that occurs at the same time as the pain is being experienced can become a conditioned stimulus for the pain. Now, of course, this doesn't happen for most people. Although chronic pain always develops from an injury, surgery, disease or trauma, the overwhelming majority of people go through an acute pain stage, followed by optimal healing of tissue or organ, followed by a return to as normal function as recovery allows, and typically with no pain. However, around 20% of people don't follow that pattern. Although they experience optimal healing, the pain doesn't dissipate. In fact, it can become more intense over time as hyperalgesia. It can consist of grossly exaggerated responses to normal sensations, as in allodynia, or can spread or generalise not only as pain in other areas, but all kinds of physical symptoms, including heat, actual inflammation and swelling, even in just one side of the body or in one limb, or one hand or one foot. The seemingly bizarre representations of fibromyalgia represent an excellent example of complex chronic pain that can exhibit all of those symptoms, and of course is usually accompanied by deeply entrenched comorbidities. This is why chronic pain frequently doesn't respond to pharmaceuticals or physical therapy or other strategies. The fact is that it's frequently no longer nociceptive in nature. The pain and other symptoms are no longer generated by the injury site, but are generated by conditioned activity in the brain. This is why sham surgery for chronic pain gets the same outcomes as actual surgery. Some people get better, some people stay the same, and some people come out much worse. It doesn't matter whether they are in the surgical group or the sham group. This is why there is precisely zero correlation between MRI or X-ray and the existence of chronic pain. This is so well known and so well accepted that MRI and X-ray are no longer indicated for chronic pain except to preclude issues such as tumour. Functional MRI shows unequivocally that chronic pain is associated with conditioned activity primarily in the amygdala region, exactly the same way that anxiety or anger or other emotions are triggered. Hundreds of studies have revealed this, and it's no longer controversial. And remember, literally any stimulus can end up triggering pain signalling. No wonder people say all kinds of weird things cause pain. It could be a change in humidity, a draft, or certain foods. And then in the chronic pain groups, you see crazy stuff like foods to avoid if you have fibromyalgia. Whole quack industries spring up around idiosyncratic condition responses of a handful of people. Just to stress how massive this issue of chronic pain signalling is, keep in mind that stimuli can be anything perceived by our five senses, whether real or imagined, and include the thoughts or words that we say to ourselves or think or feel about ourselves, our meanings and metaphors that we apply to things, and our beliefs. And any of those can become conditioned stimuli for any human response, including agonising pain. I promised we have an answer, and I'll get to that shortly, but to understand it, we have to look more closely at this mechanism of the conditioned response. The conditioned response gets triggered really fast, around 0.02 seconds, way too fast to be aware of. But that response isn't stored anywhere in the brain. It actually has to be recreated every single time. Scientists call that recreation process reconsolidation. And it turns out the reconsolidation phase is the most important part when it comes to achieving extinction using MDR. Most people who studied classical conditioning know that if we expose the subject to the conditioned stimulus but without the response, as several desensitisation strategies attempt to do, we can get a gradual fade off until the response no longer occurs. But it's slow, unreliable, and frequently not even possible because we can't remove the response, and even the slightest stimulus simply re-traumatises the person. Working with this method takes time and huge discipline, and frequently it fails anyway. There's a much faster, easier and more permanent way that is only just now becoming more widely appreciated, even though Pavlov inadvertently demonstrated it over 100 years ago. He referred to it as a failure of the response, but in fact he'd just shown how to extinguish a response by messing around with it in a particular way. If only he or others had realised the significance of this, it would have changed the course of his human history over the last 100 years. You see, it turns out that conditioned responses are not very robust at all. In fact, they're incredibly fragile. Because if we disrupt the reconsolidation phase with precision, we get extinction without effort. It's fast, it's often immediate, and it's permanent. Now, it's not just me saying this. There are many researchers working on this very important area right now, and if you Google scholarly articles related to disruption of reconsolidation of conditioned responses, you'll see a wealth of really good, high-quality studies. I will note that pretty much all of them talk about pharmacological disruption, that is injecting some substance into the amygdala region of the brain while they get the person to think about the memory that has been evoking the emotion. They haven't yet realised that there's a very powerful and non-invasive way to achieve a far superior result. Now, let's look at MDR and how we achieve disruption of that reconsolidation phase. There are three things to get right with precision. Firstly, we have to gain the knowledge and skill to appreciate the very wide array of possibilities when we're seeking to identify the client's unique conditioned stimuli. I've given a complete list of those earlier, but of course it takes some practice and some guidance to excel at that. Then we have to be able to access that reconsolidation phase. We kind of cheat on this by using a trick to extend that phase out into minutes instead of 0.02 seconds. And we do that by using the client's own idiosyncratic language that we discovered around the conditioned response. Finally, we must precisely disrupt the reconsolidation phase. If our multisensory attempt at disruption is too weak, it will do nothing. It must be at least as intense as the conditioned response in order to achieve disruption, and we achieve that via physical stimulation, along with some very different idiosyncratic language of the client. When we work with chronic pain patients, we actually have to keep in mind a twin focus. Firstly, we work with the stimuli that's directly associated with the pain response itself. An example of this is targeting the client's actual physical perceptions of the pain, or the client's metaphors or beliefs around the pain. Here, we're directly aiming to switch off pain signalling. The other focus is more general. We know, because researchers and pain specialists tell us so, that often in chronic pain there is a general central sensitization that many describe as being like a faulty car alarm. The whole system is in a kind of hyper-alert, overreactive state. So more than the general population, chronic pain patients need to pay attention to the whole gamut of things that could lead to a stress response, at least until they've solidly returned to normal functioning. This will include habits, lifestyle factors, and any comorbidities that are in play. We use MDR to switch off hyper-responses generally and help the nervous system get back to normal functioning. When people first learn MDR, unfortunately, they get caught up on the multisensory part, particularly if they've learned EFT or EMDR or some other type of physical stimulation. It absolutely doesn't matter what the multisensory stimulation is, and a monkey could learn to do it. It takes no skill whatsoever. It could be tapping, brushing, rubbing, pulling, tickling, or scratching. It could easily be stepping, hopping, dancing, or skipping. It could even be playing a musical instrument. It absolutely doesn't matter as long as it's intense enough, without causing pain, of course. If someone has facial pain, I'm obviously not going to have them brushing or tapping on their face in case I re-traumatise. If someone has allodynia on an arm, I'm going to miss that arm when I get them to do brushing movement on their limbs. The skill is investigating and identifying the array of conditioned stimuli at play and digging out the client's very own idiosyncratic language or representations of their perceptions. This can be challenging to people who've studied EFT because there's a propensity to over-emotionalise or incorrectly emotionalise the client's experience and to impose constructs on them that are quite alien to their consciously perceived experience. Obviously, that will produce only half-baked results, if any. Once we have that unique idiosyncratic language, we can very readily extend the reconsolidation phase and disrupt it. At this point, we aren't wanting to distract the client from their pain in any way, shape or form. We actually need them to really concentrate on the worst of it in order to get that reconsolidation phase up and active in order to disrupt it. Here are some examples of what typical results look like. Sally, not her real name of course, was a 9-year-old who'd been in severe full body pain for many months, joints, muscles and skin. She wasn't able to attend school anymore, and every morning her parents had to lift her from her bed to get her to the toilet because she was so weak and in so much pain. She'd actually scream out and cry with pain even at the touch of their hands on her skin. They brought her to me in desperation because nothing had worked, and the next step was going to be following through on a booking they'd already made for a 2-week hospital stay so Sally could go on strong medication combined with group therapy using CBT. Sally came in with pain that she said was 8 out of 10. Obviously, she was in considerable distress. At the end of the session, lasting around an hour, she had no pain at all and reported a slight tingling in the very tips of her fingers that she put at just a 2 out of 10 as a tingle. The next day, Sally went back to school and went back to martial arts training. She never needed the hospital stay. Now, some of these guys were individual clients and 2 were on pilot studies. Male, 48, full body stiffness that he described as waking up every morning feeling like he was made out of concrete and shooting pain down his arms then and throughout the day. At 2-year follow-up, he reported no more pain at all, the end of being a human statue, and as he said, just a bit of soreness now and then, which for a fairly inactive 50-year-old could be considered fairly normal. Female with spina bifida, complaining of pain and weakness in her legs. She had a plus 50% improvement in both symptoms, but elected not to continue treatment. Now, it's a really interesting thing about chronic pain patients. You see, they don't come to us because of the pain. Not at all. Otherwise, they wouldn't be sitting there telling us how they've suffered for 20 years. They come to us because they've reached a turning point where the pain gets bad enough to stop them from doing something they give priority to or value to. Whether that's an activity they can't do anymore, family time they can't enjoy, or a relationship that's strained to breaking point. When the pain goes below that level, unless you've got their commitment to go the distance, they often don't come back to you because in their mind they just don't have enough reason anymore. Female with nerve damage in her cervical spine, no more pain at all. Female with back pain due to severe disc degeneration, her doctor had told her the next step was surgery. Her pain was 8 out of 10, even on medication. But she didn't come because of the pain. She came because she'd had to give up her job that she loved as a librarian. And she was really sad that she couldn't lift up her little granddaughter anymore. We quickly got her pain to sit at 2 to 3 without medication. She went back to work and reported she could lift her granddaughter with ease. And guess what? She stopped coming. I would have preferred her to get to 0 pain, but like I said, it was enough for her and she didn't have a reason to return. Male with a lot of facial pain, including some shooting pain from one temple. He walked out with 0 pain. The last one I'll mention is a woman, 46, with post-surgical pain from cancer surgery. She had pain along her jaw, down her neck and into her shoulder. She also left with no pain whatsoever and was so shocked she rang me a couple of hours later after a very long drive home to tell me she still had no pain. So this is really incredible, amazing stuff. I mean, I think you can probably hear the excitement in my voice even after all this time. And it's more important for me than I can possibly describe to share this with you so that MDR can get out there and really help ease people's suffering. But there's another agenda that's also close to my heart, and I hope you don't mind my sharing it, and that's eradicating quackery. I'll say a bit more about that in a moment to explain why. We want to collaborate only with other science-based professionals so that everyone can get more reliable and predictable outcomes more quickly and more easily for more people. Now, forgive me for getting on my soapbox. Make no mistake, people have extremely limited personal resources of time, money and energy. Quackery robs people of those resources and it distracts from treatment that is actually proven to work. So it ends up delaying or even denying the opportunity to be helped, and people end up even dying because of that. Parents inadvertently kill their children because of that. The harm is both monumental and tragic. And where that alternative therapy is insurance funded, it robs and endangers the health and well-being of the entire community. As professionals working at the coalface of human health, I believe we have a deep responsibility to actively strive to eliminate quackery from the health sector and ensure people have access to science-based, efficacious therapies. So here's our mission. It's twofold. Firstly, to disseminate more effective evidence-based therapy strategies that eliminate suffering more quickly and more easily for more people. Secondly, of course, to eliminate suffering caused so unnecessarily by quackery. And yes, in case you wondered, there's a big picture vision for the future, because our mission won't succeed without it. It's our passionate goal to build a global collegial association of highly effective science-based mental health professionals, some of whom will enjoy collaborating on research together and or with us, who will provide benefit from peer support, who want to continue exploring and using MDR with a whole range of issues and disorders, and whom we can be proud to refer to, recommend and support as colleagues. Now, although this webinar is recorded for viewing at any time rather than scheduled, I really want you to get any questions answered and get any more detail that you want. So please use the comment section below to ask any questions or make any comments. I promise I'll respond as quickly as I can. Also, a complimentary copy of the textbook, The New MDR Approach to Chronic Pain Treatment, is available in the first 3 months of the training program for psychologists. While I'd love to be a charity and simply give all of this away, I'm in fact just like you and have mouths to feed too. So what I've done is develop a personally supported online program for psychologists that is also ridiculously affordable. And I've made the first month completely free, so you get to totally immerse yourself in it, get all the detail that you want, and get all the personal support and the textbook without any cost or risk whatsoever. If you want to cancel after that, it's no problem. I won't stick pins in a voodoo doll. Honestly, it's my absolute priority to just get this material out there. In this program, you'll enjoy the support of your peers as well as my support to implement MDR into your practice as seamlessly and effectively as possible. At some time in the future, you may want to consider closer supervision and even certification in MDR. You may or may not want to consider becoming a global associate whom we directly refer clients to, whom we provide educational marketing collateral and guidance, and strongly assist with practice development. We plan on providing access to ongoing specialised programs at no extra cost at all, including overweight, obesity, addiction, PTSD and others. Frankly, we just want to give you everything we've got. Because if we're to have the impact that our mission speaks to, it won't be I that achieves it. It's only the greater mass of the psychology community who can possibly achieve it. So go have a look at the link here, sign up for your free 30 days, and just kick it to the curb after that if it's not for you. We'll still be friends, and I'll just be grateful that you've got the material and can at least share it amongst colleagues. It's all good. Thank you again from the bottom of my heart for being here, for hanging on to the end. Regardless of what you choose to do, I thank you for being of service to others, for caring and being open about potential for improvement in our field, and for taking precious time to spend here. It really means a lot. So go ahead, ask those questions, make those comments. Let's talk soon.